So when there are no further questions, I would like to thank you, Thomas, and I would like to introduce and invite our last speaker of the day, Professor Xavier Rogiers, to talk about liver transplantation for perihilar cholangiocarcinoma. Thank you very much.
Thank you very much. I would like to thank the organizers for inviting me to speak about this subject, which would probably not figure on a course about 10 years ago. I have nothing to disclose. As Professor Van Gulik told you correctly, it is extremely important that we try to do resectional surgery for hilar cholangiocarcinoma, and it's important especially to have an R0 situation. You see the results. If we have an R0 situation, in all studies it's clearly better, and in our center it's the same. So how can we try to achieve this R0 situation? This is a bit difficult because we have the neighborhood of the blood vessels, and although it may be even a small tumor, and there are several procedures that have been proposed during the history in order to achieve this. You see from hilar resection of segment 1, hilar resection with hemihepatectomy, extended hepatectomy. But when the time of transplantation came along, very early, transplanters thought that that would be the ideal and most radical way of solving this problem. These small tumors that are local, but locally unresectable, that they could be treated with liver transplantation, or even with liver transplantation and Whipple's operation, or cluster transplantation, in order to be hyper-radical. And then the first publication came from Iwatsuki, showing that the results of these transplantation procedures were all clearly worse than those of resectional surgery. And so transplantation was actually abandoned as a solution for these type of tumors, and instead of that, very extended procedures, partially developed on the basis of the knowledge gained with transplantation, were used in order to have radical resection of these tumors. But there remain a number of tumors that are really very local, that cannot be resected because of bilobar involvement of the bile duct, or vascular invasion, or a combination of both, for example, portal vein infiltration on one side and bile duct infiltration on the other side, and especially also because of insufficient hepatic reserve. Think about all these patients, young patients with PTCs, with PSC, and who have a very early cholangiocarcinoma. So fortunately, actually, the Mayo Clinic developed a program in which they actually applied two principles: very strict selection of the patients and a very heavy neoadjuvant treatment, and in which they published good results, very acceptable results. Here you can see how strict this selection actually is. Radial dimension of the mass less than 3 centimeters, no intra or extrahepatic metastasis, no prior radiation therapy, no attempt at resection before, and no transperitoneal biopsy of the tumor in order to avoid any kind of spilling. And then they apply a neoadjuvant therapy, which is combined of radiation therapy and IV chemotherapy. This radiation therapy will make the transplantation more difficult, and there is an increased rate of arterial thrombosis actually in these patients. But you can see by 2000, they publish a series with an 82% survival at 5 years for those patients who actually managed to get through this protocol. And here you see this protocol again. This is 4 years later. Of the 56 patients that actually fulfilled these initial criteria, at the end, staging laparotomy is done before the patients are listed. And then liver transplantation, you see that from 56 patients, 28 patients actually finally get transplanted, and only 22 patients survival at the end. But survival ratios which are very acceptable and can justify actually putting these patients on transplant waiting lists. In the meantime, many centers have started to get on the same road, applying very similar protocols in the United States, and also some studies are going on in Europe. I have this from a publication which is not come out yet, but you can see the most important lesson maybe is that the only study that has worse results here is a study that is not applying neoadjuvant chemotherapy. Now, what questions can we ask further about this? Is it more the selection, or is it more the neoadjuvant therapy that plays a role? And a second question could be, well, if results can be so good, what should we choose? Should we choose for liver resection, or should we choose for liver transplantation in these patients? And I can give only very uncontrolled answers to this, but I make a small attempt. Mantel et al. Made a study on European patients, and from several centers in the ELTR, and you can see here in the line A are patients who all were hilar cholangiocarcinomas fulfilling the entry criteria of the Mayo study, but having had no neoadjuvant chemotherapy. And you can see that the results are clearly better than the patients who were not fulfilling. So the importance of the selection of the patients is really certainly very important. And the importance of the neoadjuvant chemotherapy is something that is probably present, but where it's unclear at this moment how heavy this neoadjuvant therapy has to be. Furthermore, in a study comparing retrospective, of course, in one center, comparing resection versus transplantation, you can see that the results using the same criteria is actually quite comparable. And there is a very recent study that is coming up, however, that is still to be published in Annals of Surgery, and that looks at 10 centers in the United States, compiled all the results. There is maybe some problems because there is only 3 of these 10 centers that actually did transplantation, but where it is suggested that transplantation will be clearly better than resection for patients with small cholangiocarcinoma. So in the basic problem that remains, of course, what do we do with organ availability? It seems that it is justifiable to do transplantation for this indication. But the question is, what is the impact on other patients on the waiting list, and especially what kind of priority are we going to give these patients? If we do neoadjuvant chemotherapy, we have to be able to follow with the transplant in a respectable time. Also, and that is an ethical question, is are we willing, are we justified to think about living donation for an indication like this? Thinking about an 80% 5-year survival, I think that would not be a problem. But if we are more liberal, would we still be doing living donation if we only have 50% 5-year survival? So, in conclusion, liver transplantation maybe, I would say, even is a viable option for hilar cholangiocarcinoma, but the correct indications and proceedings still need to be determined. And there is a huge need for prospective studies. All that we have at this moment is retrospective. And the problem in this is that these are seldom tumors, so in fact the only way would be that many centers work together in order to make these studies possible as a kind of a concerted action. I thank you for your attention.